This video focuses on nursing assessment of the thorax and lungs. Viewing this video will enhance your ability to identify common and concerning symptoms related to the thorax and lungs, employ appropriate techniques of interviewing and therapeutic communication as you gather subjective data about this body system, perform a physical assessment of the thorax and lungs, understand normal findings as you assess, and document and communicate findings from this regional assessment clearly and accurately. The outer structure of the thorax, composed primarily of 12 pairs of ribs, is called the thoracic cage. Enclosed by the thoracic cage, the thoracic cavity contains the lungs, the distal portion of the trachea, and the bronchi. Together, these form the lower respiratory system. Other structures within the thoracic cavity, such as the heart, are covered elsewhere in this video series.
When assessing the thorax and lungs, you will assess anteriorly and posteriorly. Your physical assessment of the thorax and lungs will generally involve inspection, palpation, percussion, and auscultation.
Common and concerning problems of the thorax and lungs include difficulty breathing, orthopnea, paroxysmal nocturnal dyspnea, chest pain, wheezing or tightness in chest, dyspnea, cough, mucus or phlegm, and change in functional ability.
It is important to ask your client about each of these concerns. Whenever the client indicates a positive response, use effective communication techniques to gather more detailed information. For example, Mr. Henschel is a 30-year-old man visiting the healthcare facility today for an annual examination. Mr. Henschel has a history of allergies and asthma. Start your interview by establishing rapport. Introduce yourself to the client. Explain why you are conducting the interview and how your session will proceed from health history taking through the physical examination. By exploring the features or variables of specific symptoms, you will better understand the client's perspective and be able to provide a detailed record of his experience as care progresses. Employ therapeutic communication techniques to identify immediate concerns and to address the client's holistic needs as well.
And looking here, I'm seeing that your family has no history of respiratory problems. You, however, have some allergies and asthma dating back approximately 3 years. Your last visit was 6 months ago. So how has your breathing been during that time?
It's stayed the same.
Well, can you describe your breathing for me?
Normally okay, but I still have occasional difficulty breathing, wheezing, that sort of thing. When it gets really bad, I worry I won't be able to breathe at all.
That must be difficult for you. Anxiety can aggravate breathing difficulties. Can you describe when you begin wheezing?
Well, it happens mostly outdoors, especially lately. Now that it's springtime, it's been happening about every few days.
Typically, how long does an episode last?
Well, with my inhaler, just a few minutes, but without it, it can last an hour or even longer.
Okay. Does anything make it feel worse?
Well, whenever I'm outside exerting myself, mowing the lawn, playing basketball, things like that, after it rains, the wheezing seems to clear up quite a bit.
So typically, exercising outdoors brings on breathing difficulties, especially in the springtime.
Right.
Does anything else make it worse?
No. Well, when I'm short of breath, once in a while I start to feel anxiety and I start to hyperventilate.
And what do you do when that happens?
I purse my lips and I breathe that way, and sometimes I pinch one nostril. I try to slow my breathing.
How does that work out?
Pretty good. It calms me down.
What else makes your breathing better?
Well, I stop exerting myself and I take a puff off my inhaler. That does the trick too.
Okay. I see from your record that you used an albuterol inhaler, and we renewed your prescription 2 months ago and also 6 months before that.
Yes.
Would you say that your frequency of use over the last 6 months has changed or stayed the same?
Stayed the same, meaning that when the pollen gets bad or I've been exercising a lot, I still need just one puff. I just need it less frequently when it rains and during the winter.
Have you ever been prescribed steroids?
No.
Do you take any natural supplements or over-the-counter medications for your breathing?
Nothing like that, no.
Do you have any pets?
Well, I like dogs, but I didn't think that would be a good idea.
Pets can trigger allergies and asthma in certain individuals. If you ever decide you're going to have a pet, you need to speak with your allergist again.
Okay.
Besides using your inhaler then, and stopping your exercise when you're experiencing shortness of breath, what other things do you do to cope with breathing difficulties?
On bad days, when the pollen's really bad outside, I try to stay indoors in the air conditioning. I bought a couple air filters for my apartment, and that helps a lot. It helps me sleep.
Very good. You say that your breathing difficulties sometimes stop you from exercising. Do your allergies and asthma affect any other activities of your daily living?
No, I can't think of anything else.
You say you've never smoked. Are you around secondhand smoke regularly?
No, I avoid that pretty much.
Excellent, because exposure to secondhand smoke sometimes increases the risk for respiratory problems, including allergies and asthma.
Continue to explore aspects of the client's health history, symptoms, and life circumstances to ensure a comprehensive reporting of data. Also, review all pertinent health promotion measures. For example, assess through questioning whether the client is aware of the risks of inhaled recreational drugs, occupational exposures, and household irritants such as molds, dust, radon, and asbestos. After completing your subjective data collection, document your findings in the client's health record. Be sure to report both positive and negative findings clearly and accurately. Provide details about any positive findings to give as clear a picture as possible about the client's current health concerns.
Mr. Henschel is an established client who returns to the clinic with complaints of allergies and asthma. He experiences wheezing, most pronounced during springtime, and in conjunction with exercise. Client denies chest pain or discomfort, fever, dyspnea, orthopnea, paroxysmal nocturnal dyspnea, cough, mucus, or tightness in chest. His respiratory symptoms limit his ability to maintain his exercise regimen and outdoor activities.
After interviewing to obtain subjective data, assess to obtain objective data. Be sure to prepare by performing hand hygiene and warming your hands.
For learning purposes, this video will demonstrate a comprehensive physical examination of the thorax and lungs. In actual practice, nurses may use only a subset of these techniques, depending on the client's chief concern, the healthcare setting, or other parameters. The nurse may also find it useful to conduct portions of the physical assessment at the same time as the interview, rather than conducting these tasks separately. The following tools and supplies are generally used in examinations of the thorax and lungs: examination gown, drape, and gloves, stethoscope, alcohol swabs, light source, marking pen, and an optional small metric ruler for measuring diaphragmatic excursion.
For inspection, expose only the area of the thorax that you will be examining, especially for women. Explain the rationale for the need to expose the chest to ease the patient's anxiety. Cover the anterior chest when inspecting posteriorly. Begin by observing the client's position when relaxed and breathing.
Client's posture is relaxed and upright. Client breathes with arms at sides.
Inspect the client's face for nasal flaring, which may indicate respiratory distress, and for pursed lip breathing, often seen with asthma, emphysema, or congestive heart failure.
Facial expression is relaxed.
Next, inspect the color of the face and lips, and the chest, observing for cyanosis and pallor. Then inspect the color and shape of the nails.
Color of face, lips, and chest even, and without unusual discoloration. Nails display pink nail beds, showing 160-degree angle with no clubbing.
Next, inspect the anterior thorax. Look for lesions, deformities or asymmetry, retraction of the supraclavicular or intercostal spaces, or impaired respiratory movement. Observe the client's use of accessory muscles as he breathes, and inspect the client's positioning.
No use of accessory muscles to assist breathing. Client relaxed while sitting up, breathes easily with arms by his side. Retractions are absent. Chest expansion is symmetric.
Normally, the sternum is positioned at midline and is straight, with no retractions observed during breathing. The chest wall is cone-shaped, that is, narrower at the bottom than the top, symmetric, and oval, that is, narrower from front to back than from side to side. The ratio of transverse, or side to side, to anterior-posterior is normally between 1 to 2 and 5 to 7.
No lesions or deformities. Sternum midline and straight with no retractions during breathing. Chest wall cone-shaped, symmetric and oval. Ratio of transverse to anterior-posterior is 1 to 2.
Although ribs are not visible in most people, those that are slope at approximately 45 degrees. The costal angle is typically within 90 degrees.
Ribs visible, sloping at 45 degrees. Costal angle slightly less than 90 degrees. Respiration unimpaired. Quiet, relaxed, and effortless. Rhythm is regular with normal depth, 14 respirations per minute. Chest expansion is symmetric.
Next, inspect the posterior thorax. Look for lesions and observe for configuration.
No lesions, lumps, or masses. Scapulae are symmetric and non-protruding. Shoulders and scapulae at equal horizontal positions. Spinous processes are midline. Thorax appears symmetric, with ribs sloping downward at 45-degree angle from spine. The ratio of transverse, or side to side, to anterior-posterior is 1 to 2.
Next, using your fingers, palpate the anterior thorax for tenderness, masses, and lesions following the sequence as shown. If any lesions were noticed during inspection, put on gloves and palpate them now.
No tenderness, normal sensation, no masses.
Next, assess for fremitus.
Next, I'm going to place my hands on your chest and sides in several places, and I want you to say 99 for me, okay, each time.
99.
Use the balls or the ulnar edges of both hands. Using both hands is more efficient and allows comparison bilaterally.
99.
The vibrations of fremitus should be easy to identify and should be symmetric,
99.
decreasing slightly in intensity as you move towards the base of the lungs. If fremitus is not palpable, ask the client to speak louder.
99.
Great. Normal fremitus anteriorly. Take a deep breath, please.
Next, palpate anterior chest expansion by placing your hands on the anterolateral wall with thumbs along the costal margins, pointing towards the xiphoid process. As the client breathes deeply, observe the movement of your thumbs. The thumbs should move outward from the midline in a symmetrical fashion.
Anterior chest expansion within normal range. Okay, you're going to feel my hands on your back. Let me know if there's any discomfort.
Next, using the fingertips of either one or both hands, palpate the posterior thorax for tenderness, warmth, pain, or other sensations in the sequence shown. Compare your findings bilaterally.
Client denies tenderness, pain, or unusual sensations. Temperature equal bilaterally. Okay, I'm going to place my hands on your back in several places, and each time I want you to say 99 again.
99.
Next, assess for fremitus as you did for the anterior thorax.
99. 99. 99.
Good. Normal fremitus posteriorly. Take a deep breath for me, please.
Next, palpate posterior chest expansion by placing your thumbs T9 to T10, wrapping the palmar surface of the hands laterally and parallel to the rib cage. Pinch up a small fold of skin between each thumb and vertebra by sliding the thumbs and hands medially. Observe the distance that your thumbs move apart.
Chest expansion, approximately 2 centimeters.
Next, percuss the anterior thorax for tone in the sequence shown, beginning above the clavicle, followed by the intercostal spaces, comparing sides. You should hear flatness over the muscles, resonance over normal lung tissue when percussing over the intercostal spaces, and dullness over breast tissue and directly over the ribs.
Tones normal in all areas. Can you cross your arms for me, please?
Next, percuss the posterior thorax for tone in the sequence shown. Start by percussing across the tops of both shoulders. Then over the intercostal spaces across and down, comparing sides. Avoid percussing over the scapulae because the flat tone this elicits provides no useful clinical information. Then percuss to the lateral aspects at the bases of the lungs, comparing sides. Over normal lung tissue, you should hear resonance. Lower, over the liver, you should hear dullness.
Percussion over lungs elicits resonance. Over the liver, dullness. Exhale forcefully for
Next,
please,
measure for a
and then
diaphragmatic
hold it.
excursion. Ask the client to exhale forcefully, then hold his breath. Beginning at T7, the mid-scapular line, percuss the intercostal spaces of the right posterior chest wall, moving downward until the tone changes from resonance to dullness. Mark this level and allow the client to breathe.
Now breathe and take a deep breath and hold.
Next, have the client inhale deeply and hold it. Percuss the intercostal spaces from your mark downward until resonance changes to dullness. Mark the level and allow the client to breathe.
And breathe.
Measure the distance between the two marks. Then repeat the procedure on the left side.
Excursion is equal bilaterally, 3 centimeters.
Prior to auscultation, use an alcohol swab to clean the diaphragm of the stethoscope and warm the diaphragm with your clean hands before bringing it into contact with the patient. Lung auscultation is easiest to perform with the patient sitting. Auscultate, beginning anteriorly while making sure not to listen through clothing, gown, or drape. Your goal is to identify normal breath sounds, as well as abnormal sounds including wheezes, rails, rhonchi, and stridor.
Every time you feel the stethoscope, take a deep breath through your mouth, okay?
Place the diaphragm directly on the chest wall and auscultate in the sequence shown, from the apices of the lungs slightly above the clavicles, to the bases of the lungs at the 6th rib. Listen at each site for at least one complete respiration. Depending on the area auscultated, normal breath sounds vary from vesicular to bronchial and bronchovesicular.
Breath sounds normal. Every time I place the stethoscope, breathe through your mouth, please.
Auscultate the posterior thorax. Again, making sure to listen with the stethoscope placed directly against the skin. Stand behind and beside the client and listen from the lung apices to the bases and then laterally in the sequence shown. Listen for one complete respiration each time. If breath sounds are too soft, ask the client to breathe deeper. Remember to include the lateral fields. Identify the breath sounds by listening for their intensity, quality, pitch, and duration of inspiration versus expiration. Depending on the area auscultated, the normal breath sounds may be vesicular. Low in pitch, breezy in quality, soft in amplitude, long during inspiration, and short during expiration. Or they may be bronchovesicular. Moderate in pitch, mixed in quality, moderate in amplitude, and with the same duration during inspiration and expiration. Careful subjective and objective assessment of the thorax and lungs is critical for all clients. Accurate gathering, documenting, and communicating of findings can help to optimize a client's existing function and initiate critical steps for any needed interventions. After completing your objective data collection, document both positive and negative findings, using the correct phrasing of the documentation of normal findings as demonstrated during the assessment. Mr. Henschel's condition is not changed from his last appointment, and today's results continue within the range of normal for his age and existing medical diagnosis. To continue to help preserve his function, the nurse reviews ongoing health promotion measures. You need not wait until after your assessment to address these issues. Instead, weave patient education throughout your interaction with the client whenever appropriate. Today, the nurse concludes her session by ensuring the client's understanding about how to use his inhaler, how to exercise properly given his health history, how to manage instances of hyperventilation, and the importance of controlling his exposure to allergens both in the home and outdoors. The nurse educates Mr. Henschel about how to spot symptoms that suggest his problem is worsening and provides her client with pertinent literature. The nurse also encourages Mr. Henschel to follow up with his allergy specialist and primary care provider.